All right, thank you, and good evening. I do not have any financial disclosures. All right, so at Nationwide Children's Hospital, we're part of the Molecular Characterization Initiative, which is a part of the National Cancer Institute's Childhood Cancer Data Initiative. This is a national collaboration between the childhood cancer community, the Children's Oncology Group, providers, patients, and families. And the goal of this project is to provide state-of-the-art molecular characterization informing diagnosis, prognosis, and therapeutics for sick kiddos. A component of this molecular profiling is we refer to as SDGC, or your somatic disease germline comparator. So you're going to have peripheral blood for your constitutional or germline. You're going to have FFPE or SNP frozen for your tumor tissue. And we're going to run an enhanced tumor normal exome with a target depth of 250x. We're going to have increased coverage over our cancer-associated genes. We're going to perform targeted review of over 900 plus curated genes, and we're going to report germline and somatic variants, CNV and LOH. And again, we're going to provide diagnostic, prognostic, and therapeutic criteria. So the first patient seen at NCH for MCI was back in March of 2022, and as you can see, it's a pretty steep rise in the number of cases that are seen every month and keeps our clinical team really, really busy. And so this is reality or challenge number one that I want to talk about. Challenge or reality number two is the fact that we have these guidelines and frameworks, and we really want these guidelines and frameworks to be interoperable. And so everyone here is going to be familiar with panel A, where you're seeing, your evidence levels and your significance tiers for your AMP-ASCO-CAP guidelines. And Malachi Griffith in the workshop yesterday for bioinformatics did a really great job going over the oncogenicity guidelines that came out in 2022 that really mirror the 2015 ACMG guidelines, and we have our specific codes as shown there. But what we really want is not only to be able to have that overall classification and have that be reproducible, we also want to be able to, a better scenario, have the codes associated there. So if you look in panel C, we can have these discordant classifications from different institutions. And if you're able to have those evidence codes reported as well, sometimes you're actually able to reconcile the differences between these discordant classifications. But the best scenario here is actually having the evidence lines for each of these codes stored within the information as well. So then you can actually go from the place where your producer here has assigned, SBS2 and OP4 with their specific evidence of E2 and E1 to your consumer actually changing that and moving that to likely benign because they did not agree that the evidence in evidence 1 actually met the code requirements for OP4. If you want to learn more a little bit about the way that we're kind of putting all of this together and standardizing the data for this, please attend Katie's poster at number 72. So our way that we wanted to handle this is we wanted to build a tool for our variant scientists. We refer to this as VARCAT, hence my shirt. This is the variation categorizer. And this is an example of what you would see when actually using this tool. And to blow up a couple here, we have one, we're assessing BRAF V600E within your pilocytic astrocytoma. Here you can see that this is an active assessment, so we'll show your assessment status and who's currently doing that, along with historical evidence on who did the initial review and the final classification. You'll see at the very top, we'll have our overall classification, here being oncogenic. It might be a little hard to see, but you have the applied evidence with its total score. For those of you who are familiar with those oncogenicity guidelines on the Bayesian framework, you can also see that we have support for their AMP-ASCO-CAP tiers. Under that, we have our more general statements that are going to be your high-level statements supporting each of these different categories and the codes. And these specific statements have been handcrafted by our clinical team and are plugged in with variables and will go directly to our reports. So here's a look at the top part of the oncogenicity classification, and you can see a couple different sections here judging different parts of the SOP. As you can see, we try to automate as much of this as we can for our clinical scientists to help reduce the amount of analysis time going on, and so we have this purple computed here showing where we're able to do that. And then you can see the specific code that was chosen by your specific analyst. And as noted above, we really want to be able to capture the evidence supporting this code that you can see in each of these boxes. You can also see the overall points that have been assigned and if that's actually been modulated. So this is going to be the default amount of points for code OS2. So having built this tool out, I wanted to actually try classifying 100 different variants from pediatric cases that we had already done. And here's just a snapshot of the different kind of genes and the previous AMP-ASCO-CAP tiers that were assigned to these specific variants. So before I get into the actual results, there's a couple things that I want to make note of. There is specific efforts going on with our clinical team on furthering to establish the guidance for how to assess well-established in vitro and in vivo functional studies. And here's a couple high-level notes of the things that we're thinking about here. And we're also trying to use as many of the recommendations from the Burnich et al. Paper in 2022 to help judge our functional studies. And this is something that's really needed for consistency when assessing these functional studies. Another thing that we're considering on changing and updating is adding to the code OP2 the ability to consider two-hit hypotheses. So for example, here, if you have CNLOH of 9q, including patch 1 in your germline sample with no other findings in your SHH genes, plus you have a somatic finding in patch 1, this being, TRP 926 ARG with a previous assessment of a tier 1 level B. And so trying to use that as well to help support your overall classification. And we also have a change that we specifically made to our functional domain code here at OM1, where we're making it so that you cannot apply this code in tandem with OVS1, which really is getting at a null variant within a tumor suppressor, making sure that it's only applicable for your missense and your in-frame indels, and making sure that you're not only checking protein domain tracks and databases, but literature to help support your overall assessment there. The reason why that's important and why we didn't automate this specific code is highlighted by this example here, where we're looking at a SMARCA4 variant, this R1243W. And if you look at PFAM, you can actually see that it's highlighted outside the helicase C domain. However, if you go to UniProt, it's clearly denoted and marked that it is in the helicase C domain. And interestingly, the functional evidence that was chosen to actually be applied to this overall variant was this paper, which did a functional assay and showed that this specific variant had the exact same effect as other variants within the helicase C domain, hence supporting our assessment that we believe that this would actually fall within this domain. So here's how it all shakes out. On the very right, the numbers add up to the total number of classifications. On the bottom, to not confuse you, those do not add up to the number of classifications. They add up to the number of times that code was applied. And so you can see we have all of our different overall classifications from benign to oncogenic and the different codes that were applied. Of note, I highlighted OS1 and OM4. These codes are specifically designed for when you have already had those variants previously assessed using these guidelines. There is very little to none, depending on the variant, of this information that is publicly available for these variants having been assessed using these guidelines, and hence we were not able to actually apply these codes. However, in our tool, we have it built that if these variants have been classified in the past and you meet the criteria for it, that would auto-trigger these specific codes. Also, OP2 was not used. Again, this is right now a very niche case, and the example would be RB1 in retinoblastoma. The other thing to note on this table is OS2. What I show here in the parentheses is the number of times that that was chosen to modulate or downgrade functional strength from +4 to +2 moderate. And then here's how the overall classification shakes out, right? And this is something our clinical team was quite concerned about when they were thinking about applying this within our own workflows, is how do the oncogenicity guidelines and the AMP-ASCO-CAP guidelines work out together? And specifically, they were worried, well, what if we have a tier 1 level A that gets classified as a VUS? What does that mean? Well, I can tell you now, in my small case study, that we actually had no issues with that. There was none of our Tier 1 level A variants that were classified as VUS. They were all either oncogenic or likely oncogenic. As you can note on the far right of this, we don't have any Tier 3 or Tier 4 variants that I did assessments for here, and so we're not really concerned about those, and we don't generally actually report those. Interestingly, what I thought was pretty cool was actually that we have 8 of these Tier 2 level D variants that are classified as oncogenic. And the point here is really all of these are null variants within tumor suppressors that may not have a therapeutic target right now, and hence really we need to be able to start reporting these and understanding these so that we can figure out how to actually target and treat these specific variants because they're clearly doing something. The other thing that I thought was quite interesting is the fact that you have 35 variants that were classified as oncogenic compared to Tier A being 19, and so how kind of all that pans out is going to be really interesting as we move forward. But really, again, our key takeaways from this are that we have Tier 2D variants that are classified as oncogenic because there are null variants in tumor suppressors, and these need to be identified and looked at so that we can help these patients. And again, to alleviate some of the questions that our clinical community has, in this small subset, none of our Tier 1A variants were classified as VUS. So in summary, VARCAT is a tool that will enable us to perform rigid and reproducible variant oncogenicity classification, and it uses this genomic knowledge model on the back end to store variant classifications with evidence codes and supporting data to enable reusable variant classification information, and this is something that we want to help provide the community with. So there's a QR code up the top here, which will provide you a link to my slides. It'll also provide you a link to a Google form that you can fill out if you're interested in learning more about VARCAT or collaborating. This is a tool that we will be making open source to help support the community, and we would love your feedback. There's also a couple of questions on there to just help me understand how I can be a better presenter for professional advancement. And I would like to thank everybody on these slides, and please check out these posters of all my awesome lab mates who do a bunch of really cool research. Thank you so much for your time and attention.